Hi everyone, thanks for listening to my presentations. Today I'll be talking about syndrome of inappropriate antidiuretic hormone lesson 3. And if you are listening to lessons 1 and 2, which I would advise that you listen to if you haven't, I have promised that lesson 3 will be all about treatment and some warnings, some precautions to take when we are handling the affected people with this disorder. With that in mind, let's go. Treatment of syndrome of inappropriate antidiuretic hormone. First thing first, after we have taken our history, done our physical examination, made a diagnosis, the next thing is to treat the underlying cause. Let's have hormone replacement in adrenal insufficiency. Is this hypothyroidism? Let's correct appropriately. Are we dealing with meningitis here in any form? Of course, the neck stiffness, the rigidity, the fever, and other signs will point to that. So let's give appropriate antibiotics. If it is viral, let's handle appropriately. Is this tuberculosis? Let's treat. Is this pneumonia? There are so many presentations that you can get on pneumonia here. Now check my channel, you'll see a lot on pneumonia. If this is secondary to certain medications or even street drugs like ecstasy, let's stop the offending drugs. Okay, you have tried to handle all those that I've just said. The first thing to be written on the prescription sheet is fluid restriction. And you could be specific. Less than 800 ml per day. But you might not be comfortable to do that if the cause is subarachnoid hemorrhage. I think you could see now. So it's not everybody that we're going to write fluid restriction for. Because if it is secondary to subarachnoid hemorrhage, that is not the issue. You can use your IV fluid, this time around hypertonic saline, 3%. You give 20 ml per hour. And of course, you have to take serial sodium measurement because that's what you want to correct, right? So 20 ml per hour of 3% hypertonic saline. You could go another direction, giving the affected person high solute intake. You can have high sodium and high protein intake. The sodium could be administered in form of sodium salt tablets. You are going to get 1 gram per tablet, and you could, depending on the level of the sodium, so you give as may be appropriate. The affected person could also be given urea. And while doing all this, you can combine that with furosemide. Then, when you are using furosemide, be careful with the level of potassium. Okay? So you can have salt plus furosemide, which means you give your sodium tablets that are hypertonic, and you give your furosemide, which is a loop diuretic, a high saline diuretic, that will increase the rate of water excretion and lowered urine osmolality. You can add potassium sparing to the above to save the potassium. Still on treatment, you may go another direction. You can decide to choose antidiuretic hormone or vasopressin receptor antagonists. And there are three receptors when it comes to vasopressin. That's what we call V1a. That will cause vasoconstriction. Okay? V1b will mediate adrenocorticotropic hormone release, while V2 will mediate antidiuretic hormone response. Okay, you can then go to choose your vasopressin receptor antagonist, and that will produce selective water diuresis without losing sodium and without losing potassium. However, the individual placed on this medication will have increased test. So, for example, you can give your intravenous Conivaptan. And remember, Conivaptan will block both V1a, which is going to mediate vasoconstriction, and block V2 receptors that will be mediating ACTH response. V2 selective, that is ACTH response, are Tolvaptan, Mozavaptan, Satavaptan, and Lixivaptan, all Vaptans. If the hyponatremia is very severe, which means you have very, very low level of sodium, you can combine Conivaptan. Remember, that will block V1a, vasoconstriction, and V2, ACTH response, with hypertonic saline. Mostly, fluid restriction and salt tablets will be enough in most cases. Let me repeat. If you don't want to spend money, or you are in a rural area or in your jurisdiction, you can't even get all these medications that I've mentioned, don't worry. Fluid restrictions with tablet will be enough. But for the physicians, for the nurses, and for the patients, even healthcare aid and family members, fluid restriction is so much a difficult thing for people to comply with. Do you know why? You do. You see the fluid all around, they eat, it's their normal life, so it's a big issue. So most of the times we run into a lot of difficulties having to settle quarrels between nurses and the family of the patients, and even the patients themselves, because the doctor has written the prescription, fluid restriction, don't take anything above 1 liter per day. So you have to measure the fluid they take every time, and they don't go beyond it, and they don't want to hear that. So it's a difficult issue. But to those who adhere to that, fluid restrictions with sodium tablet will be enough. Warning. I'm not a military guide who should be warning people or giving command, but for the sake of healthy lifestyle for the people we're dealing with, we need to adhere to some precautions. Rapid correction can lead to irreversible neurological damage. And that will give us what we call osmotic demyelination syndrome, ODS. So somebody is down with low sodium, hyponatremia. Oh, you are so concerned. You are so energized. You are so, I don't know. You are so overzealous and you want to raise it fast. You are going to do more harm than good. Osmotic demyelination syndrome was formerly known as central Pontine Myelinolysis. Okay? The problem is that the brain has adapted to the hypotonic environment. But that is not the case in people with severe hyponatremia within hours. I mean, if the hyponatremia has occurred just in the last few hours, okay, you can then do your correction in few hours also. But to someone who has been battling with hyponatremia for days, for weeks, for months, have that at the back of your mind that adaptation must have occurred to the hypotonic environment. And they'll come down with futures when you rush to correct that hyponatremia. What are you going to be battling with? Seizures. So you'll be surprised this patient maybe was not symptomatic before, but when you are too aggressive to correct the hyponatremia very fast, the patient is now not jacking before you. Seizures. Dysarthria. They won't speak right again. They go into coma and they could be in locked-in state. They will hear, they will see, they won't respond. Have you done more harm than good? Yes. So don't rush. So it's a warning. Urea is encouraged in Europe, but my European friends are not comfortable with Vaptans. Oral urea is used in some centers, so you make that research on your own. Find out whether your jurisdiction will be comfortable with the use of urea or not. Demyelination or lithium will decrease collecting tubule response to ACTH, giving less reabsorption and increasing water excretion. So you could use demyelination 300 to 600 milligrams per oral twice daily. Confirm from your pharmacist and what you are doing now as part of the protocol at your center. The rate of correction, because the other time I've just given the warning, don't rush, don't do, then what is do? Is it all the time you say don't? Then what are you going to do? The severity of the hyponatremia will determine the rate of correction. If the hyponatremia is less than 120 milliequivalent per liter, rapid rate, but not too rapid, will be good, and not too rapid place to avoid central pontine myelinolysis. If you are dealing with level 120 milliequivalent per liter to 129 milliequivalent per liter, then do your correction very slowly. Generally, in chronic hyponatremia, what you're going to do is it should be less than 8 milliequivalent per liter in 24 hours if you are going to increase the value of sodium. Maybe you can be between 4 to 6 milliequivalent per liter in the first 4 hours if you are dealing with severe symptoms. And for the remaining 20 hours, you can now go above 4 to 6 milliequivalent per liter. If you are dealing with reset osmotat, there is no need of correction. I will make a separate presentation on reset osmotat. You can watch my channel for that in the next few weeks. So I will not waste your time going over that here right now. Asymptomatic patients do not need any urgency. So, for example, in them, you can give 100 ml of 3% or hypertonic saline and that will increase sodium by 1.5 milliequivalent per liter in men, and 100 ml of 3% saline will increase sodium by 2 milliequivalent per liter in women. The increased serum sodium will pull water out of the brain and decrease cerebral edema. You can repeat the above 2 to 3 times within 10 minutes apart. That is giving 100 ml of 3% saline. So, boluses of hypertonic saline can help very fast, but please measure the sodium level every 2 to 3 hours. Why? Your target is 4 to 6 milliequivalent per liter rise in sodium per day. You don't have the luxury of shooting up the level of sodium so fast. So measure the level of sodium every 2 to 3 hours, please. Finally, when it comes to the treatment of syndrome of inappropriate antidiuretic hormone, you pause and go through this list. All this will be useful. So doesn't mean you have to use all of them. It might be only 1 or 2, but this is what you can get on your table and you go through while you're handling them. Oral salts, oral urea, decreased fluid intake, high saline diuretics furosemide, dimethylcycline, lithium, hypertonic saline 3%, Tolvaptan, Conivaptan, and you can suspect reset osmotic if the person with hyponatremia is stable in the face of mild syndrome inappropriate antidiuretic hormone because they don't need therapy. And with that, I come to the end of this presentation. The next presentation will be on reset osmotic. I hope this will be useful to somebody somewhere. Physicians, nurses, family members, and affected individuals. Kindly subscribe to my channel so that you can get these presentations and more immediately they are published. Thank you, I appreciate it.